Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today's webinar is updates to enhanced barrier precautions. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. So if you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday for more of our weekly webinars. Next week's topic is taking control of adverse events. If you're interested in joining, that will be the same time and place next Wednesday at 2 p.m. And now I'd like to introduce our speaker today, Dr. Jean Storm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again today.
Thanks, Kathy, and thank you everyone for joining. So I know you're here today because enhanced barrier precautions have recently become a requirement in all of your facilities. So we're going to be talking today about what they are, why we are implementing them, and I'm going to also share some examples. There have been some questions directed to us at Quality Insights about all things enhanced barrier precautions, and I'm going to be bringing up those scenarios at the end. If you have any questions, we also can address those at the end, just to make sure that you are avoiding all citations during survey and making sure that you're keeping your residents safe, which is what we all should be doing as our primary goal. So objectives, today we're going to be talking a little bit about MDROs, cause, spread, colonization, who is at risk. We're going to be talking about what the CDC means by enhanced barrier precautions, and I'm sure you all have an idea at this point what enhanced barrier precautions are. We're going to be talking about implementation of enhanced barrier precautions in the nursing home population. So I thought we would start with a case. And this is a case, I'm sure it's similar to many that you've encountered in your facilities. A 64-year-old female is admitted to a skilled nursing facility from a hospital stay for sepsis and chronic kidney disease. Hemodialysis was initiated during the hospitalization, so a tunneled dialysis catheter needed to be placed. So this is an external device that has been implanted in this resident. 26 days after her admission, she is found to have a temperature of 100.2 and a heart rate of 108. Initial labs are drawn, but she is discovered to be unresponsive the following day. She is sent to the hospital and diagnosed with MRSA bacteremia from a dialysis catheter-associated infection. So patient cases like this, resident cases like this are very, very common, but they're preventable. There's a lot of things that we can do to prevent infection in this resident. And really, it's the day-to-day care with residents where we can have the biggest impact. And that's where enhanced barrier precautions come in. So when we talk about MDROs, I'm sure you talk about them all the time in your facilities on a daily basis. So these are bacteria that are typically resistant to one or more classes of antibiotics. They've just developed a resistance, and the resistance typically comes because we use so many antibiotics. So that is how bacteria develop resistance. And they're frequently resistant to the most common antibiotics. This is why they're so difficult. Then we have to escalate our antibiotics, and that puts our residents at risk for more resistance. And then, of course, C. diff infections, we're going down that line. MDR infections are tough and they continue to expand. We're having more and more and more. They're associated with longer hospital stays, increased costs, higher mortality, and they've increased dramatically and they continue to increase dramatically, especially in nursing homes. So when we think about colonization versus an infection, colonization means that there is a potential bacterial pathogen. So there's a pathogen present on or in an individual's body, and it could cause an infection. Colonization increases risks for infection, but it doesn't necessarily mean that the resident has the infection. And I know sometimes that line can be a little bit blurry, but we really have to look at the whole resident. Individuals who are chronically ill, immunosuppressed, recently admitted to the ICU, and I will say just the hospital at large, are at increased risk of developing infections that they're colonized with. We know that when we send residents to the hospital, they get more resistant bacteria. They're at risk of getting all of those resistant bacteria from the hospital. That's why we have to be really careful about just sending residents to the hospital. We have to really keep it in mind because our residents get exposed to more MDROs when they're in the hospital. So when we talk about enhanced barrier precautions, what is the rationale? So residents in nursing homes are at increased risk of becoming colonized and then developing an infection from MDROs. We know that half of our residents, maybe even more, are colonized with an MDRO. If we only look at residents who have an active infection, we really fail to address the risk of continued risk of transmission. And there's increased evidence that traditional implementation of contact precautions in nursing home is not implementable for prevention of MDRO transmission. So we know enhanced barrier precautions are going to prevent that transmission of MDROs from resident to resident. And it's not necessarily going from directly from resident to resident. It's going from staff to resident, staff to resident. So that's the cycle that we're attempting to break with enhanced barrier precautions. So enhanced barrier precautions refers to the use of gown and gloves during high contact resident care activities. And during these activities is when MDRO transmission, so when MDR transmission from staff to resident, from resident to staff, that's when that's going to occur. That's why we wear gown and gloves, because we're preventing that transmission. Because, you know, when you think about it, when you perform care, when you roll a resident, or when you have the device, like with a peg tube or with a trach, you know, that's getting on your skin, that's getting on your clothes, and then, you know, you're transmitting whatever is on your clothes onto that resident's peg tube or whatever. So there's a lot of transmission going on. So MDROs may be indirectly transferred from resident to resident during those high contact areas. That's via staff. So nursing home residents with wounds and indwelling medical devices, like I talked about, a peg tube or a trach or a dialysis catheter, these residents are high risk for acquisition and colonization of MDROs. So EBP, enhanced barrier precaution implementation, is the use of gown and gloves for high contact resident care activities. This is when contact precautions do not otherwise apply. And I'm going to be pulling up a chart at the end so kind of you can tell. And then we also have a preview of a tool so you can kind of tell if you need to utilize contact precautions or if you need to utilize enhanced barrier precautions. So this is, again, utilized for nursing home residents with wounds and or indwelling medical devices, as well as for residents with MDR infection or colonization with reportable MDROs. So what are high contact care activities? High contact care activities is dressing, if you're helping a resident with dressing, bathing, showering, transferring, providing hygiene like brushing teeth, combing hair, changing briefs, assisting with toileting, linens, device care or use, central line, urinary catheter, feeding tube, trach. So anything that is an external device that is going into a resident, like a catheter, a peg tube, anything like that, if you are using it to give medications, if you are cleaning it, anything, if you are touching that device, you need to be utilizing enhanced barrier precautions. You just kind of have to get it in your head. If I'm touching the peg tube, I need to be using enhanced barrier precautions. Wound care. Now, wound care encompasses a lot. You can refer to the CDC frequently asked questions or ask us if you would like for questions about wound care and enhanced barrier precautions, physical and occupational therapy, because typically there's a lot of high touch associated with therapy. So chronic wounds. The intent of enhanced barrier precautions is to focus on residents with a higher risk of acquiring an MDRO over a period of time. So these are residents with chronic wounds have a higher risk of acquiring an MDRO over time. We're not talking about skin breaks. We're not talking about skin tears that you can cover with a bandage. We're talking about wounds such as pressure ulcers, diabetic foot ulcers, unhealed surgical wounds, chronic venous stasis ulcers. I'm going to say with wounds, just because these regulations just became mandatory, if in doubt, now we're not talking about a skin tear, we're not talking about a skin break, but if you are in doubt with a wound and if you should have to use enhanced barrier precautions, I would probably err on the side of using them if you are concerned. If it were me, and this was a facility where I was medical director and they were asking me and there was a resident with a wound, I would say go ahead and use the enhanced barrier precautions if I was at all maybe could go both ways. Indwelling medical devices, central vascular lines, our dialysis catheters, our indwelling urinary catheters, feeding tubes. These are our peg tubes, JG, whatever feeding tubes we're using, tracheostomy tubes. So I went through those fast. So all of those, these are examples of indwelling medical devices. And again, if you have questions, you would like to reach out to us, please do. We can ask at the end of the webinar. Things to consider about enhanced barrier precautions. These are enhancing the current standard and transmission-based precautions. These are gown and gloves used for each resident during high contact resident care activities and removed after each resident encounter. We, of course, always want to make sure that we are solid with our hand hygiene and it's performed and new gown and gloves donned before caring for a different resident. So always are utilizing our hand hygiene before and after. It is not recommended for residents with C. diff, Clostridioides difficile. This is when we have to utilize our isolation and contact precautions, just because C. diff is a spore that is highly resistant to cleaning. It's very easily to be transferred. That's why we're very careful with C. diff. Residents who need enhanced barrier precautions do not require a private room, and they don't need to stay in their room. So we are utilizing enhanced barrier precautions during those high contact activities that I outlined previously. More things to consider. This is intended to be in place for the duration of the resident stay into the facility, unless the wound has resolved or the peg tube has been removed or the trach has been removed and they no longer have an indwelling medical device. So those would be the reasons why we would stop enhanced barrier precautions. But it's intended for MDRs and MDROs and do not replace existing guidance regarding use of contact precautions. I will say, though, that the enhanced barrier precautions should remain in place if we determine that the resident is colonized with an MDRO that is reportable. Enhanced barrier precautions are primarily intended to apply to care that occurs within a resident's room where we have high contact care activities. This is transfers and are bundled together with other high contact activity. So, we really should not be doing care with a peg tube out in a common area. Like, that is not appropriate, because if we're doing any type of care or using an indwelling medical device like a trach or like a peg, we need to be utilizing our enhanced barrier precautions. So we really shouldn't be doing these things in common areas. It's just not good practice. We can get into a lot of other issues around resident rights and all those things if we do that. So it's really best to take the resident to their room and then utilize our enhanced barrier precautions and then do the care in the room. Does it work? It works. That's why it's required. This works to keep residents safe. So this was a study that was done in JAMA. It was a long time ago. It was 2015, so almost 10 years. This looked at enhanced barrier precautions in 203 residents who had indwelling devices in 6 different nursing homes, and they compared them to another 200 residents as a control. They utilized barrier precautions on the doors of their rooms, in their closets, at the nurse's station, and on their medical records. This included active surveillance for infections and MDROs. They had hand hygiene promotion and a structured infection prevention education in the control group. And infection preventionists in the facilities were invited on a conference for surveillance methods of infections. So when they utilize enhanced barrier precautions in this group, there was a 23% reduction in the prevalence of all MDROs. So they reduced the prevalence of MDROs in the intervention group. There was a reduced incidence of new MRSA acquisition in the intervention group. So when enhanced barrier precautions were utilized, there was a reduced spread of MRSA. So they reduced, new individuals acquiring MRSA. There was also a reduction in catheter-associated urinary tract infections in the intervention group compared to the control group. So it works. Enhanced barrier precautions are going to prevent the spread of MDROs from resident to resident, prevent the new acquisition of MDROs, and they are also going to prevent infection. That's why they are required, because they save people's lives, because sepsis is one of the most common causes of residents going to the hospital and dying. Private rooms are not required. Single rooms should be prioritized for residents who have acute infection with a communicable disease, such as influenza, hepatitis A, COVID, or for residents placed on contact precautions if a resident has acute diarrhea, if they have a draining wound, other sorts of secretions that are unable to be covered or contained, then we should prioritize the private rooms for these residents. Residents with enhanced barrier precautions may share rooms. Facilities with the capacity to offer single-person rooms or create roommate pairs based on MDR colonization. That is really good practice if we know that a resident is coming into the facility and they have a known reportable MDRO, and we have another resident already in the facility with a known reportable MDRO. To cohort these residents is good practice, and then utilize enhanced barrier precautions with both residents. And if there are multiple residents with the same MDRO in the facility, then consider cohorting them together in one wing to prevent the spread to other residents who are not colonized with that MDRO. Again, I think this is is that a double slide? No. So when single rooms are not available, cohort residents with MDRO in the same patient care area. And then if cohorting patients, residents with the same MDRO is not possible, place MDRO residents who are known colonized with residents who have a low risk of colonization with an MDRO. So, and are likely to have short lengths of stay. So no open wounds, no invasive medical devices, are not immunocompromised. So all of these things you can kind of be thinking about when you're going to decide where you're going to place a resident. So this is the chart that was included with the guidance from CMS about the requirement for enhanced barrier precautions. And I like this because you can kind of go through, and I don't know if you're a chart person. We also, West Virginia Healthcare Association put together a tool, which is a flow chart, which is it's kind of similar to this. Again, however you understand things is how you're going to use things. So if you like charts, there's this one, and then the tool will be available. We're going to preview that at the end of the presentation. So if you have a resident who is infected and colonized with any MDRO and has secretions or excretions, they're unable to be covered. That is not enhanced barrier precautions, that is contact precautions. If you have an infected or colonized with a CDC targeted MDRO, so if you have a resident who has an infection with an MDRO, a CDC targeted MDRO, or they are colonized with a CDC targeted MDRO, they do not have a wound, they do not have an indwelling medical device, and they have no secretions or excretions which cannot be contained, that is when we are going to utilize our enhanced barrier precautions. And those residents are going to stay on contact or enhanced barrier precautions throughout the duration of their stay because we know that they are colonized with a CDC targeted MDRO. If you have an infected or colonized, if you're a resident infected or colonized with a non-CDC targeted MDRO without a wound, now this is the tricky one. If you have a resident with an infected or is infected or colonized with a non-CDC targeted MDRO without a wound, an indwelling medical device, or secretions or excretions that are unable to be covered or contained, this is that you can use enhanced barrier precautions. Nobody's going to tell you don't, but this is at the discretion of the facility. And I will say, MDROs are changing all the time. You are going to prevent spread when you utilize enhanced barrier precautions. So that is my guidance. You're going to prevent spread, which is good. Resident has a wound or indwelling medical device and secretions and excretions that are unable to be covered, then of course we want to utilize contact precautions because we have excretions that are unable to be covered and are not known to be infected or colonized. So enhanced barrier precautions, they have a wound and an indwelling medical device, so that is enhanced barrier precautions. Has a wound or indwelling medical device without secretions, so we have a wound and an indwelling medical device, then we know we do enhanced barrier precautions. Again, case by case, some are going to be challenging. Reach out, ask questions. We will all put our heads together if it's a challenging case. CDC has signs. Make sure that we are really pushing hand hygiene and making sure, we're saying high contact resident care activities, dressing, bathing, showering, all of those kinds of things. So signs in the residence room, we don't want to put it outside the residence door, right? Because of privacy, but we want to make sure that they're put in such a way that all staff understand what we're doing. So intended to signal, they're supposed to kind of signal staff, this is what we need to do when we enter this residence room. Sign must contain information about the precautions and the recommended PPE. And generic signs that instruct individuals to speak to the nurse, really not adequate, because often those are overlooked. Signs should not include information about the resident's diagnosis or the reason for the precautions. You don't want to put on the door, this resident has an highly resistant MDRO, obviously. We can't do that due to resident dignity. So these are some resources that are available. We will be, the PowerPoint will be available to you. I just wanted to kind of cover two issues that recently came up since the enhanced barrier precautions were required. A facility reached out and asked about colostomies. Now, colostomies themselves are not an indwelling medical device. So a colostomy is the resident's own body part. It's not a device that's put in like a PEG tube. So colostomy in themselves are not, we don't need to utilize enhanced barrier precautions. But if the resident has a CDC reportable targeted MDRO and they're colonized, doesn't matter about the colostomy. So we use enhanced barrier precautions because of the CDC targeted MDRO colonized status. So not the colostomy. And one of our QIS has reported that a facility had a citation recently because they, during a survey, during MedPass with a resident who had a PEG tube, that the medications were administered and the staff member was not utilizing enhanced barrier precautions. So if you are doing anything with that indwelling medical device, you should have enhanced barrier precautions. Should be glove, gown, and gloves. Anything with an indwelling medical device. So I think those are the two things I needed to cover.
Dr. Stern, we have a couple of questions. Do you want to tackle those first or show the tool first?
Sure, we can do the questions.
Okay, so I have two questions plus someone who's raised their hand. I'll read the questions first, and then to the person who raised your hand, I'll give you the ability to unmute yourself here in just a moment. First question says, is there a resident we should not place in a room with a person on EBP?
So if you have an immunocompromised resident, then it's going to depend on why the resident is on EBP. So if the resident who is on EBP is colonized with a CDC targeted MDRO, and that is why they're on enhanced barrier precautions, I would not put that resident in a room with a resident who has a wound. The resident who has the wound is going to have enhanced barrier precautions, but like you have to really be thinking about who you are cohorting. So if you have a resident that doesn't require enhanced barrier precautions and they're immunosuppressed, I would not put them in a room with a resident who has enhanced barrier precautions. So the cohorting is really going to depend on why the resident has enhanced barrier precautions. And these are cases, again, some are complex and they really need to be thought out and talked out, and you might need to, reach out to us. We have Jennifer Brown, who is our infection preventionist extraordinaire, and she can answer tremendous amount of questions. We get together if there's a complicated question and kind of discuss it amongst ourselves, because a lot of these cases are very complex. So like I said, it's going to be a case-by-case basis.
Okay, thank you. The next question is, it looks like a sort of scenario. It says, example, a resident has a GT site is covered with dressing, resident not colonized, keeps clothing on to cover the GT. Would EBP be needed when in restorative?
So if you are using or handling that, I'm thinking GT is G-tube, PEG tube. If you are at all touching that indwelling medical device, then yes, you need to use enhanced barrier precautions. But if it is contained, it is not being touched, it is inside the resident's clothes, then I would think you are safe to have restorative with that resident without enhanced barrier precautions. Though I'm going to say with survey, like, is that resident known colonized with an MDRO that is, CDC targeted MDRO? Like, if they're going to look through the resident's chart and find that they are colonized and you're not using enhanced barrier precautions, I think if you're doing any kind of therapy with that resident, then you probably should be using it. But if it's just around the G-tube, then, and it is closed and you're not touching it at all, then I would think you don't need to use enhanced barrier precautions. And if any of my QISs disagree with me, you can kind of chime in.
All right, so we have two more questions. I'm taking these in order. So I'm going to allow Dorothy, I see your hand is raised. You should be able to unmute yourself if you would like to ask your question out loud now.
Okay, can you hear me?
Yes.
Yes.
Okay, my question is similar to that restorative question because when the QSO came out, it says EBP should be followed when performing transfers or assisting doing bathing in shared common shower rooms and when
Yes.
working with a resident in a therapy gym. So if the patient is on EBP or the resident is on EBP, so when he gets into the therapy gym, that means that the therapist should also be gown and gloving up at that time also.
Yes.
And that's not going to create a dignity issue or
Well, I mean, it's challenging, right? It is a very, it's a challenging thing, but the guidance is, again, I think, if you have you know, if we see residents who, and this is done in their room, but if they have C. diff, they still have some therapy, but, typically it's done in their room. But, I mean, this is the guidance. So I honestly would be safe if it's a resident who is colonized with a CDC targeted MDRO. I think during therapy, just this is the guidance. I would probably follow those guidelines.
okay. So if they're colonized or are infected and we're using EBP, I have a indwelling medical device, chronic wounds, anything that we're using inside the patient's room when he has EBP. Once
Yes,
they go to the gym, we should continue to use the EBP intervention, right?
that is per the guidelines.
Okay. All
I
right.
don't know if any of my QISs have a different slant on this. I'm like a physician, so I know physician gut viewpoint is sometimes different from nursing viewpoint. But I will say I would just be right now, I would be very careful with his guidance and I would just try to follow it to the letter because, this is new for everyone.
Okay. Okay. All right. Thank you. That was my question.
Yep.
Thank you for your question. And the last one that we have in the Q&A so far says, many different answers when it comes to E. coli as targeted MDRO. Any insight?
I would just follow that CDC, and I should have included that. I think it's on the tool. I believe it's on the tool. Maybe we should pull up the tool.
Yeah, I was going to say, why don't we make sure that we include that link with the follow-up email? Because there have been lots of questions in regards to what is considered a targeted
Yes.
MDRO. And I know what I would have thought would have been on that list is not on that list. So it's something that we are constantly looking at and referencing when we answer these questions. And I do think we will also follow up in the email. So maybe Kathy, if you can, the questions that are in here, if we can get a copy of those questions and maybe we can add answers to these questions with supporting documentation because I can't find it. When you want something right at the moment, you can't find it at your fingertips. But I don't think that they need to have EBP in the therapy gym unless you're toileting them in the therapy gym.
Yeah.
So, and I do think that that was answered in one of the frequently asked questions. So if there's a way that we can get all the questions that were in here, and then we'll provide follow-up answers to all these questions with supporting documentation.
I will say it's very challenging because, and like I said, this is all like, because this is, required. This isn't new, but the requirement is new. When they say physical and occupational therapy, my concern is that you have different surveyors in your facility that are, I want to say it's, they are seeing what they're seeing. So, what if you're in the therapy gym and like Deb pointed out, the resident has to go to the restroom and someone assists the resident to the restroom and EBP is not utilized, then we're in trouble. So, I think we just need to be like, right now, I think we just need to really follow it to the letter just to be safe.
And the email that I think Deb is referring to, just for everybody who's on the call, I will be emailing everybody probably on Friday, maybe even Thursday, depending on when things are all together, pulled together, to send everybody a link to the recording for this webinar and the presentation slides and any of the resources that we're discussing, including the one that should be on my screen right now. You guys let me know if you can't see it. I think I have it up though. And this tool is one that is not approved to go out yet, but it's pretty much done. And we're going to walk through that. And before we continue, I see there's a couple more questions coming into the Q&A, and we will circle back to the Q&A, I think, after we walk through this, but keep sending us your questions. We'll have time for everybody.
I just wanted to, before we move on to the new questions, I just wanted to put in the chat the MDROs that are targeted by CDC. And of course, like if someone has an active infection and they need contact precautions, that's different. So I'm just going to put these in the chat for you guys.
Thank you. And Deb and Jean, I will send you also the questions that people submitted to us if there's any materials you wanted to send in that email. And thank you, Jen.
Yeah, if you see all the
I actually see the one question, because I just read this yesterday. Do housekeepers need to gown and glove to clean a room if the resident is not in the room? And the answer is yes. If that room is an EPP room, EBP room for that resident, yes, they do need to follow those precautions, even if the resident isn't in there, because they're cleaning areas that resident has had high contact with.
If you think about it, you know, if what we're trying to prevent is for the MDRO to getting on the staff's clothing, because that's what occurs. You know, you do some kind of care, or you change linens in the room and you kind of ball them up, and you don't know, you know, things are rubbing against your scrubs, your clothing, and then you know, go on to the next room. You do hand hygiene, but those MDROs are on your clothes, and then you're going into the next room. So that is transferring that MDRO. That's why we're using a gown and gloves. So we are, you know, leaving those in the room.
There's also two very good, and Kathy, maybe we can include these links as well, two CDC YouTube videos on this topic. One was only like a 3-minute short, down and dirty, and the other one was an hour, but they were both very good at explaining some of the do you or don't you need to use the precautions when you're going into those rooms.
Yeah. So this is the guidance, and this is similar to the chart, but it's a little bit easier. If you just want to scroll down, you can kind of ask yourself, does the resident have an infection with an MDRO, acute diarrhea? And you can kind of scroll down and ask yourself each of these questions to see if you're supposed to utilize enhanced barrier precautions or standard precautions.
And I think that one person's question, if you go up just a little bit, Kathy, that one person's question regarding C. diff would not in itself would not be enhanced barrier precautions. That would be contact precautions, because that's an active infection. So I think sometimes we, and ourselves included, because with that question when it was asked, we need to make sure we're not confusing an active infection that already requires regular contact precautions versus enhanced barrier precautions. There's two different things.
Right. Right.
And someone asked if they will be sent this sheet to print off. Yes, this will be in the email that I send to everybody on probably on Friday. I will have a link to this document that we are previewing right now. It is still being reviewed, and once it's approved, we'll send it out on Friday. Jean, Deb, do you want me to scroll further down or take a closer look at this? Is it close enough that you can read it okay?
This is, no, yeah, this is fine. I think we got to the end. I mean, this is going to be very helpful for you. I would, print this out and put this up in your facilities. I think it's going to be great to kind of tell what you should be utilizing. I think we have more questions coming into the chat.
Yes, we do. So if you want,
it's an active chat today.
It is. All right. Well, going in order, the next one is with the facility discretion in regard to the non-targeted MDROs. Is there some guidance that you can provide as for this decision-making process?
So this is a very challenging question. As a medical director, I would sit down with my nursing home administrator and my director of nursing, and I would go through all of our residents who are of MDRO colonization, who has a CDC targeted MDRO, who has a non-CDC targeted MDRO. I'll see where they are, what are the numbers, and according to the guidance, this is at your discretion. So in my mind, that means that you're not going to receive a citation because you are not utilizing enhanced barrier precautions with these residents. However, we know that enhanced barrier precautions prevents spread, reduces the spread of MDROs from resident to resident. So take that as you will. I would look at your numbers and kind of see, is it possible? Can we do this? But I think that this is going to be definitively just a facility to facility question. It's a tough one. I'm sorry it wasn't, I didn't have a more clear answer and say, no, you definitely should utilize them. If it were me and I was a medical director and my director of nursing was asking me, I would say, yes, we should use them. But I know enhanced barrier precautions are a big undertaking. It is a big undertaking to get them implemented with the residents that are required to have them. So that's why.
And I'll add to that I've had a couple facilities that they have had a large number of history of MDROs, and they have worked with their county health department to determine what additional history of MDROs should be included on that targeted list for their area. So it is going to be specific to the facility, the type of residents that you take, and what has been the history of infections at that facility.
Yeah, if you can get something from your pharmacy to look at the bacterial resistance in your facility, that would be really interesting. I know some pharmacies do offer that.
I can take the next question, Kathy. It says MDRO located in urine, treatment completed, where's brief, still stays in EBP question mark. If that is still an active infection, then it's not EBP. It's your contact precautions or precautions for the MDRO that's in the urine. So if it's still an active infection, it's contact. It's not EBP.
They say the treatment is completed.
But if the MDRO is still present in the urine and they wear a brief, so just because they had the MDRO doesn't mean they're in EBP. So maybe we need more information on that, but I'm reading that to mean you don't have the infection cleared. Even though the treatment is completed, you don't have a negative culture. That's how I read that question.
Well, I will say, this is how I don't know if are we talking about if we're talking about colonization. So if the MDRO is still located in the urine and we are determining that resident is now colonized with a CDC targeted MDRO, then we have a known colonization. So I think I don't know if we're talking about, this is an anonymous person. Is this a resident who we rechecked the urine and we determined that the resident was colonized? I don't know. They're not answering.
So the person who asked that question, maybe you could elaborate a little bit more. Oh, they said no. So would you need to recheck to determine colonization?
So again, this is a tricky question. We typically don't check for cure. So this is what I will say. If you treat this resident, and I'm going back to Deb, do you see how I'm going both ways?
Yeah, and I think, and I know where you're going. I think you first need to look at what is your policy pre-EBP? What was your policy to take them off of isolation? That's where you need to start. What was your policy to take them off of active isolation?
Yes. So
once they are off of that, then you would look at, was it a targeted MDRO or wasn't it, to determine whether you need EPP?
Yes. Yeah. So some facilities have a policy where you do need to check if it's an MDRO check to ensure that treatment is complete and they're clear. So I would agree, because you have to do whatever is in your policy.
The person who asked the question said, right, this is where we have the confusion.
Yeah, so you go back to your policy and kind of start backwards. They had an active infection. How would have you taken them off of active isolation? And then look at, are they a candidate for enhanced barrier precautions?
If it was a targeted MDRO, and if it's an active infection, then they have an active infection. Yes, a targeted MDRO enhanced. Yes, they need enhanced barrier precautions
after your contact precautions are finished.
Correct. Right. I thought that's what they were saying.
Yeah. I just want to clarify that. Yeah.
So you see, it's a very challenging. It is a very challenging, because things change rapidly with our residents. Yes, you're welcome. I don't know if we answered that third question you had. The same resident who was on therapy when therapist required to wear a gown when ambulating also requires feeding assist for feeding, is able to sit at dining room table with other residents, and the staff is not to be gowned. So again, this is a tough, if you're saying that the resident is on therapy and there needs to be enhanced barrier precautions when ambulating, feeding is in the guidance for direct care activities. I don't know if anyone feels differently about this.
Hello?
Yes.
So if a resident is being fed, and he's being fed in the dining room, you cannot use gowns and gloves in the dining room. And that's once, if you're just feeding the resident, that's considered a bundle of high contact, or it's just one, you're just feeding the resident. I think for me, and I want to make sure I got this right because I have to talk to other people about it too. So if you're feeding someone and you're not in that patient's room, right? And you're in the dining room, you shouldn't have gown and gloves on, because that's a dignity issue.
I would agree. I think that you would get into trouble with
feeding is on the list, that it's not a requirement.
But is it in the room?
Yeah, because it's not considered a bundle of high contact activities. It's just
yes, agree.
Okay.
Someone commented feeding isn't on the list of activities.
Okay. For some reason, maybe I was confusing it with the feeding tube. I saw feeding.
Now, are we done with this question? We have someone with a hand raised and that's been waiting. I was going to call.
Okay, go ahead.
Okay. All right. So Abigail, you should be able to unmute yourself to ask your question now. Or if you've changed your mind, you can lower your hand if you don't have a question. I know sometimes people hit the hand by mistake.
So Hannah said, other education I have attended stated PPE for EBP should not be used in common areas, dining room, ambulating, and hallways. I just would be, like I said, I would be very careful. You know, if the resident needs to go to the restroom, we need to make sure, you know, because sometimes things happen seamlessly. That's the only reason why I said we have to be very careful, you know, because if you're taking a resident to the restroom from ambulating in the hallway, then we need to be utilizing EBP.
All right, thank you. And so far, that is the last of the questions we have received, aside from that one hand that is raised. And you could unmute yourself at this time, Abigail, if you would like to ask your question out loud. And if not, I will run over some closing items, and then anyone else who has any last second questions can slip those in. Okay, you lowered your hand, so I guess that means you didn't have a question. So that means, okay, I will run over some closing items. If anyone else has a question, please submit it using either the chat or the Q&A tool in your Zoom menu. And I just realized my video's been off. Sorry about that. And while we're waiting, I'm going to run over some closing items. So I'd again like to invite everyone to next week's webinar, which will be called Taking Control of Adverse Events. That webinar will be next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. One of our quality improvement specialists there will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and our webinars in the newsletters that we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can contact me at caudill@qualityinsights.org and I will get you on that list. And I will drop my email in the chat right now and look to see if there's any other questions, which I don't see. So everybody can take just another moment if they want to ask their questions. And before we sign off, Dr. Storm or anyone else here have anything else to add before we close? I think Dr. Storm is shaking her head.
It's a really complicated topic. I will say, you know, as a medical director of facility, you know, it's very complicated and there's a lot of gray areas. So I really appreciate everybody's, you know, all their questions.
Kathy, this is Penny. I want to mention too, and you mentioned the live chat, but really there's somebody on the live chat on Tuesdays and Thursdays, and we're always happy to hear your questions if you've had an experience with something. So joining the live chat gives us an opportunity also to possibly hear what your questions might be, answer your questions or find the answers to your questions. And so that's another opportunity for you to interact with us also.
I think there was one last question.
There is one last question. It says, has any facilities had any surveyor in their facility since the EBP guidelines were implemented? If we are confused, I am sure the surveyors will be confused.
I think, Deb, you heard of a facility, right, that had a survey?
Yeah, so there was facility that had a survey. Some of it was surrounding tube feed. Some of it was surrounding the fact that there was clear signage that a resident was to have enhanced barrier precautions in place and staff were not following them. So I think that is confusing for them as much as it is for you. So I think the important thing is to make sure that you know who's on enhanced barrier precautions, because that was another thing that the facility had stated, that when they talked to the infection control nurse, they didn't know who was on precautions, or if someone was on enhanced precautions, they didn't know why they were on the enhanced barrier precautions. So I think it's real important to have that open communication with the staff that, they know what the signage means. Do they know why they're on the precautions? And especially that the infection control nurse knows, maybe the staff puts somebody on because somebody starts with a pressure ulcer and they have wound treatment. We need to make sure that we're communicating that to the infection control nurse that enhanced barrier precautions were started so that she can track that as well. I think it all comes down to communication and knowing why they're on the precautions.
Yeah, I would definitely agree.
Someone else asked, can you send the link to the 2 videos? I actually do have those handy because we were going to stick it in our newsletter this week. So here they are. Deb, make sure I put the right ones in the chat, but I'm pretty sure these
Yes,
are the
they
right
are.
ones.
That's correct.
And I'll include the links to those in that email that I send out later this week.
And just know that it's, you know, you guys are all as confused as sometimes we are, and every situation is unique in its own way. So, you know, just talk amongst yourselves, talk with us, and we'll try to work through each scenario. And I know we try to find supporting documentation to answer your question so that if you are asked by a surveyor, hopefully you can have readily available guidance in writing from CDC of why you made the decision that you made to put them in or to not put them in.
All right, thank you, Deb. Does anyone else have anything else to add before we sign off, before I wrap us up? And of course, when I email everybody, I'll include Dr. Storm's contact information, where you could just respond to me if you have a follow-up question. I can put you in touch with whoever can answer your question. And I think I can go ahead and wrap us up then. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It's anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Dr. Storm and everyone on the panel today, because everybody was tapping in on the questions today. Thank you for joining us and for answering all the questions. And I'd like to thank everybody here for joining us today. And we hope to see you guys again here next week.